Well, good evening, everybody. Do you hear me?
Yes, we can hear you.
Good evening, everybody. Welcome to another CPD webinar organized by the CPD Committee of College of General Practitioners of Sri Lanka. I am Dr. Priyadashika Hidipitiyage, the moderator today. Today's topic is heartburn, the clinical approach to a burn in Sri Lankan topic. Let me introduce our speaker today, Dr. Nilanka Wickramasinghe, a young, versatile professional. Dr. Wickramasinghe entered to Colombo Medical Faculty with flying colors at the A-level examination, and she was graduated from Faculty of Medicine, the University of Colombo, with second upper class honors in 2014. Following that, she obtained a M.Sc in Human Nutrition at the Postgraduate Institute of Medicine, University of Colombo. She topped her batch and was awarded the Best Student Award Gold Medal by the Postgraduate Institute of Medicine, University of Colombo, as well as the Gold Medal for Best Performance at the M.Sc Human Nutrition Examination in 2019, which was awarded by the Sri Lanka Medical Nutrition Association. Following the interest in nutrition, she joined the Department of Physiology, Faculty of Medicine, University of Colombo, as a lecturer in gastrointestinal physiology in 2018. She completed the PhD in gastrointestinal physiology from the University of Kelaniya and is currently performing the clinical service of GI physiology investigations at the National Hospital of Sri Lanka. Deeply interested in medical education, she obtained her postgraduate certificate in medical education, certificate in teaching in higher education, and SEDA accreditation in UK. She also received 4 Teaching Excellence Awards from the Faculty of Medicine, University of Colombo. She also authored a medical book called Simplified Physiology of ECGs. Dr. Nilanka obtained 2 President's Awards and 1 Merit Award for scientific publication from the National Research Council. She delivered a Sir Marcus Fernando oration at the Sri Lanka Medical Association Foundation sessions in 2024. She was also awarded the prestigious United European Gastroenterology International Scholarship Award in Vienna, Austria, and Asia Pacific Award, Asia Pacific Advanced Network Fellowship in Pakistan. Furthermore, she was chosen by the International Union of Physiology Sciences for an IUPS Junior Faculty Award for the year 2024. She also awarded the Professor K. N. Seniviratne Memorial Research Award from the Physiology Society of Sri Lanka. She is a feminist and pursuing a PG diploma in gender and health. Dr. Nilanka holds key positions in organizations such as the Social Secretary of the Sri Lanka Medical Association and the Secretary of the Colombo Medical School Alumni Association. Her passion is health education from the public, for the public. And if I don't introduce Dr. Nilanka as a well-trained a popular singer and a pianist, my introduction would not be completed. Dr. Nilanka, it's over to you to enlighten us on heartburn. Thank you.
Thank you for that very long introduction. Thank you very much. Very nice of you. And I thank the College of GPs for inviting me for this topic, which is actually quite close to my heart. Heartburn, quite close to my heart, I would say. I hope you all can hear me well. So the topic I've chosen is heartburn, a clinical approach to a burning Sri Lankan topic. And this is actually, as I told you, just Yeah, as I told, this is a topic close to my heart because this is gastroesophageal reflux disease in Sri Lanka was the topic of my PhD research. So today's talk or lecture is based on my research as well, and the things I learned from my PhD for about 4 years. So another disclaimer, I am not a consultant. I am not a gastroenterologist or anything to do with the surgery. So this is based on my research and my training as in Physiology studies. So let me move on to the topic on heartburn. So when we talk about heartburn, we automatically think of certain things. And as clinicians, what we think is basically it's something to do with gastroesophageal reflux disease or GERD, or there can be people who might think, okay, this is related to gastritis or other things. But mostly what we have learned in medical faculty is that it's related to gastroesophageal reflux disease. So let me talk on these titles. So first I'll take you through historical outline, and then I'll talk about what is GERD, the prevalence of GERD symptoms, associated factors, diagnosis, management, and the psychological perspective and conclusions, all related to Sri Lanka. I'm not going to talk just merely about the international findings or the guidelines. I'm going to talk correlating it to the findings, research findings we obtained recently. So if I talk about the historical snapshot, so heartburn has been described even in the early historical anecdotes. So it was the physician Galen who in 200 AD experimented on Roman gladiators and coined the term heartburn. So apparently he's the one who coined the term heartburn based upon the observation that the diseases of the esophagus often mimic the diseases of the heart. And symptoms of GERD are described in even Ayurveda, where they talk about Agni or biological fire, etc. And throughout the ages, many herbal remedies have been concocted, and then afterwards, alkaline medications were in vogue, like bismuth, white oxide of bismuth, and all. But it was just only in the early 1900s that gastric acid was identified as the cause of esophagitis by Chevalier Jackson, who is considered the father of endoscopy. And it was during the same era that the surgeon Norman Barrett observed the histological changes in the esophagus of GERD, which is now termed as Barrett's esophagus. And afterwards, in the 1950s, Rudolf Nissen developed fundoplication or Nissen's fundoplication for the surgical management of GERD. But however, the formal measurement of acid in the esophagus was described only very recently, if you consider the years, in 1960. And it was the scientist Johnson and DeMeester who utilized for the first time in 1974 24-hour pH monitoring for diagnosis of GERD, which is now considered the gold standard for diagnosis GERD. And even omeprazole, it's a very drug we often use. It was also just approved in 1988. It's quite, I would say, quite a new drug, and now it's being used worldwide. So I think I gave a kind of a very short overview of gastroesophageal reflux disease coming from GERD. Now I would like to go on about what is GERD. Let's talk about what do you mean by GERD. So GERD is a condition where the contents of the stomach reflux back to the esophagus, and it causes symptoms such as heartburn and acid regurgitation, and in the long term it can cause complications such as esophagitis and esophageal cancers. And the pathophysiology of GERD can be categorized as supraesophageal factors such as impaired reflux-induced follows. Then there can be esophageal junction-related factors such as hiatal hernia. Then esophageal body-related factors such as ineffective esophageal motility, and gastric-related factors such as delayed gastric emptying, which can all lead to gastroesophageal reflux disease. And if you talk about symptoms and conditions associated with GERD, we often talk the typical. Let me just get my pointer into a laser. So we only talk about the typical heartburn or regurgitation, but there are many atypical symptoms associated with GERD, from jaw pain, halitosis, cough, asthma, chest pain, bloating. So these are atypical symptoms of said to be atypical symptoms. Now let's go on to now let's go on to the prevalence of GERD symptoms. I'm sorry, my prevalence of GERD symptoms. The global prevalence of GERD symptoms, if you define it by heartburn and or regurgitation at least once a week. So if you take a look at all the systematic reviews there are, the consensus they have come to get all these studies together and have a common definition, symptomatic definition of GERD, is that it's heartburn and or regurgitation at least once a week. And in a systematic review done in 2020 by Nirvan et al, reports that it's about 14% worldwide global prevalence. And as you can see, it's higher in Western countries and lower in the Eastern countries. But you will notice that this picture is from his the systematic review manuscript. But you will notice that Sri Lanka is not included in this systematic review. And so what about it? And this is what part of my PhD research was. And we published the GERD prevalence in Sri Lanka. And how we did was that we went across all over Sri Lanka to 25 districts of the country, all 25 districts of the country, and recruited 1,200 participants using stratified random sampling. And we found that the GERD symptom prevalence of heartburn and or reflux at least once a week was 25.3%. That is at least 1 in 4 individuals were suffering from heartburn and or reflux at least once a week in Sri Lanka. We found that the highest prevalence was known to be in districts of Monaragala and Mullaitivu, and the lowest was in Trincomalee. So when in our statistical analysis, we found that there was no effect on urban-rural settings on GERD symptoms. And alarmingly, nearly 40% of our population were on GERD medications and nearly 20% were on proton pump inhibitors. So I'm pretty sure that omeprazole and PPIs are now in the same level as Panadol being prescribed all over. However, we should know that PPIs are supposed to be prescription-based medications only. So as you can see, the GERD symptom prevalence of Sri Lanka is quite higher than the global prevalence of GERD. And if we go into associated factors, the common associated factors, now this image shows the associated factors which are found in other systematic reviews, etc. And you can see that there are factors related to diet like chilies, spices, oily or fried food, carbonated beverages, etc. Diet related habits like consuming large meals, sleeping after meal, etc. Then mental stress, obesity, hiatal hernia, disease conditions such as asthma associated with GERD. Then sleep habits such as lack of sleep, sleeping position, and certain medications, smoking, all of these are well-known associated factors in Sri Lanka. And in our study too, we found that increased mental stress, inadequate sleep, sleeping within 2 hours of a meal, skipping breakfast, and snacking at midnight, all these factors were associated with GERD in Sri Lanka. And of this, mental stress played a major role, and we published our further findings on this in another journal. Look at the food types. I'm sure everyone must be wondering, okay, this type of food causes heartburn for me. This is the food, or when I eat bread, when I eat this, when I eat that, I get heartburn. So when we looked at it, we found that nearly 1/3 of Sri Lankans of the 1,200 population. This is not the patients with GERD or participants classified as GERD. This is the 1,200 population. Nearly 1/3 of them complained of heartburn on consuming food such as spicy food, oily food, then bread, right? And to a lesser degree, wheat and sour food like tea, sour food and then tea, etc. Now, of this, bread is an interesting finding because it is not listed as an associated dietary factor in any worldwide literature review. So it was basically our Sri Lankan study was the only one which talked about bread, and we were quite fluxed as to how to talk about it. But I'd like to discuss further research we did on this topic of bread causing heartburn later on in my presentation. Now, if you look at this crowded table, I'm sure you don't have time to read it, but there are many diseases with symptoms overlapping GERD, such as, say, gastritis, eosinophilic esophagitis, achalasia, disorders of gastric motility, cardiac diseases, you can name it. There are so many diseases which can be differential diagnosis for GERD. So we went on further and did a case control study, because earlier what we did was we basically did a symptomatic diagnosis of GERD, which so those patients could have anything else also. So here we took, in this study, we took patients with endoscopy positive GERD patients, and we took age and sex matched healthy controls. And we found that lower family income, asthma, consuming a midnight snack, inadequate sleep, inadequate recommended physical activity levels, and high stress was significantly associated with GERD. And the GERD patients were thinner than controls. Now, this is weird because, again, obesity is supposed to be a cause for GERD, but in our patients, we found that they were thinner than controls. And this is probably due to the fact that we put so many dietary restrictions on patients with GERD. Don't eat that, don't eat bread, don't eat this, just eat something very light, etc. And very predictably, their daily caloric intake was also less in patients with GERD. So I hope I'm not going too fast, but I just like to cover a lot of factors related to GERD. And let's go on to talk about diagnosis of GERD. Now, this picture summarizes the methods of diagnosing GERD. So we can talk about clinical history taking, GERD screening tools, your response to PPIs, etc. We can do barium studies, and most commonly we do endoscopy. And endoscopy can diagnose patients, GERD patients who have developed the complication of erosive reflux disease due to acid reflux. Now, this is important. Not all GERD patients will have erosive esophagitis or evidence of esophagitis. There is a subsection of patients with gastroesophageal reflux disease who have no evidence of esophagitis on the endoscopy, and they are called non-erosive reflux disease, or NERD, N-E-R-D. And in fact, ERD, that is erosive reflux disease patients, are just 30% of a cohort we followed up with GERD, we underwent endoscopy. And so what about the rest? What about the rest of the patients whose endoscopy is negative? What do you do about them? And that is where the gold standard diagnosis comes to play. That is the combined 24-hour pH evidence testing, which is according to the international guidelines, the gold standard. And mind you, this test is not a research test. It's simply not a research. Some people think that this is only done at research centers. No, it is not. In UK, this is done very commonly in many patients. The issue is that it's quite an expensive test to do because these catheters are quite expensive. So other than that, if you want, I can talk about the prices and how much a catheter is, etc. later on. But because of the expenses, it's not very common in Sri Lanka. So the name of it is combined 24-hour pH impedance testing. And here, I'd like to discuss a little bit about this because it might be something new to people. So there are two elements being tested in the esophagus using specialized nasogastric catheter with sensors. So one is pH. So you can see these two circles have encircled a pH sensor, two pH sensors. So one is this is put through the nose, and this will enter the stomach, so it will measure the gastric pH, and this will be put in a way that it is positioned about 5 centimeters above the lower esophageal sphincter, so it can observe whether there is any acid reflux. Then the other parameter is impedance, which I will talk about later. impedance is something similar to electrical resistance. I'll explain it further later on. So you can see there are more sensors to measure this impedance. And this pH impedance data is fed to a device worn outside the body. So it's something like a Holter monitor, like what you do with ECGs. And the patient also has to input symptoms, meal times, etc. And they wear this for about 24 hours. And during these 24 hours, if the pH of the esophageal pH sensor falls to less than 4%, less than 4 pH, for more than 4% of the 24-hour duration, we can classify it as GERD. This is kind of a standard way of saying it. So again, I'll tell it. If for more than 24 hours, for 24 hours, if more than 4% of the time duration is at pH less than 4, you can see over here, pH is less than 4, then we can call it as GERD. But if the pH doesn't fall less than 4, like that, it is a control or a healthy patient. But you can see that in a normal patient also, there can be little refluxes which are absolutely normal and absolutely physiological. So let me talk about impedance. This is just one slide. Don't worry, I'm not going much into physics and all that. But when I talk about impedance, I said, is similar to electrical resistance. So we'll have, so just imagine that there's a catheter here. And the impedance electrode is over here, and one impedance electrode is here. And if we swallow some liquid, we all know that electrical resistance is less in water. That's why it will be electrocuted if you go to a bathtub with a hair dryer or in the outside in a wet day. Whereas impedance is higher, or electrical resistance is higher in air. So that's why air doesn't conduct electricity. So if of some water, if we swallow water and this water goes through, passes this impedance electrode over here, it will measure impedance and it will show a reduction in the impedance over time while it passes. Conversely, if a patient swallows air or swallows some gas, when the gas bubble passes this impedance electrode, the impedance will increase. So there are several impedance electrodes all over this catheter. So we can get many different patterns of reading based on this different air going up. Could it be a liquid swallow, could be an air swallow, could be a liquid reflux or acid reflux or air reflux. So we can identify various patterns using this. And what we are looking for is a liquid reflux pattern. And once we identify this liquid reflux pattern, we also look at something else, which is a symptom association. Now, in some patients, they would have a symptom. Now, I told you that they have to feed in that little gadget. We ask them to input their symptoms according to times. So if they are if there's an impedance reflux, and at the same time the patient has noted a symptom, a heartburn symptom, we can say that there's a positive symptom association. But in some patients, they won't have a symptom associated with any reflux. So you can see that the patient has said there's a symptom, but there is no reflux in this area. So there is no symptom association. I hope this was not so confusing, but according from all this data, there's so much of data we can get from this 24-hour impedance monitoring. We can classify patients into either symptomatic GERD, where we identify increased reflux with positive symptom association. We can have asymptomatic GERD patients who are incidentally sometimes diagnosed on endoscopy, but they say, okay, I don't feel any heartburn, but they could have increased reflux plus negative symptom association. We can also find a category called reflux hypersensitivity. These patients will have normal physiological reflux. I told you that it's completely normal to have some reflux within, say, 4% of a time of 24 hours. And if this normal reflux is associated with a positive symptom association, we call it as reflux hypersensitivity. So he or she is sensitive to even the normal reflux. Then in the fourth category, which is called functional heartburn usually, there is normal physiological reflux, or there is no abnormal reflux, and there is a negative symptom association, meaning that the patient is inputting saying that, oh, I'm having heartburn, I'm having heartburn, I'm having heartburn at this time, but we no reflux episodes recorded on the our monitor. So either if there is no alternative diagnosis, we can classify them as having functional disorders. So functional disorders is kind of a polite way of saying it's something psychological. And these patients are usually called functional heartburn, or if they have chest pain, we can say it functional chest pain. Right. So what did we find in the Sri Lankan context? So in our research, we looked at patients at National Hospital, and we took about 209 patients, recruited 209 patients with GERD symptoms, and we found that endoscopy is done in about 95% of our patients. But only 23% of the cohort underwent pH impedance testing. So pH impedance testing is done at the gastroenterology unit at the National Hospital of Sri Lanka. If you refer to the gastroenterologist there. This test is done at the National Hospital and in a few other hospitals around Sri Lanka as well. So only 23% of the cohort underwent pH impedance testing. And if you categorize the 209 patients, you can see that we were able to categorize only less than 50%, because about 50% of the patients were unclassified, or 57% of the patients were unclassified because they did not have pH impedance testing done on them, only endoscopy. And if endoscopy is negative for erosive disease, we cannot give them a diagnosis. So I didn't go into detail to describe this because of the time factor, but what I want to tell you is that what happens is most often when there are patients with heartburn and we just do endoscopy and we don't find any evidence of esophagitis, that's just a dead end for the patient. It should not be so. We should be able to refer these patients for further investigations depending on their situation. Right. And what about the patients who underwent pH impedance testing plus endoscopy? So we had about 46 patients who underwent both impedance testing plus endoscopy. We found that only 28% of them, these red and light red, were patients with GERD. That is, they had more reflux than usual. And about 18% of them in yellow were diagnosed with reflux hypersensitivity. And about 13% of them were diagnosed, that is in blue, were diagnosed with functional heartburn. The rest are in gastritis, etc. So this is kind of, how do I say, this is why we have to know about these other categories of functional heartburn and reflux hypersensitivity. So let's go on to the methods of diagnosing GERD. There's another investigation I'd like to mention, and that is upper GI manometry or upper gastrointestinal manometry, where we look at pressure patterns of the esophagus during swallowing. And this is a normal reading, and this test is also done together with pH impedance testing for several reasons. One thing is the position of the pH catheter has to be done, measured using this manometry method. And also if you're going for say a fundoplication or any other surgical method, we need to have evidence of about how your esophageal pressure patterns are during swallowing. So these two, esophageal manometry and pH impedance testing, are done both together. So one thing we realized that in our cohort, about 46% of them have infectious esophageal motility. That means that their peristalsis was not strong enough, and another large percent, about 61% of our patients, had hiatal hernia, which also we can diagnose using esophageal manometry. Okay, so that was about diagnosis of GERD. Let's talk about management of GERD. So again, this is another picture where I illustrate the management options of a patient with GERD. These are pictures taken from my thesis. So the three management option arms are lifestyle modification, medication, and then surgical and endoscopic procedures. So lifestyle modifications, what are recommended in international guidelines are things like elevate the head end of the bed, have the left lateral position to sleep so that the anatomy of the stomach will help the acid not to reflux, to avoid oily food, trigger foods, fizzy drinks, etc., to avoid meals before bedtime, to have smaller meals, to avoid excessive exercise, to lose weight, to stop smoking, and also very importantly, stress reduction. Medications are usually PPIs, then H2 receptor blockers, and there are PCABs, which are used in other countries but not in Sri Lanka, and there are many other drugs we can use. Endoscopic options are Stretta, TIF, and things like that, which are rarely done in Sri Lanka. And the research about the use is kind of controversial, but fund application is done in Sri Lanka at very few centers, and it's usually a surgical option which are meant for patients who are treatment resistant and who are diagnosed with pH impedance as having GERD. Now, I'm not going to go through this very crowded flow chart, but what I'm trying to show is that in this image, we have amalgamated the current worldwide management guidelines from American, British, European, and Asia Pacific guidelines, etc. All of them start with confirming GERD. I'm not going to go through all of this, but what I'm trying to show is the guidelines start by confirming GERD. Unfortunately, in our Sri Lankan situation, we do not confirm GERD as regularly or frequently as we should. So let's see what we saw in our setup. And so like I told you, Sri Lanka doesn't have our own management guidelines, and we didn't have much research on current practices. So again, we followed up these 209 patients at the start, then 6 months and 1 year, and we looked at the medication they use. So you can see that this is the types of medications they were given, prescribed at the beginning, and around 90% of our patients were prescribed PPIs, as seen in this blue color column. However, at the end of the year, nearly half of our patients, right, nearly 50%, as seen in this green column, were not on any medication. So they just have fallen out of the grid and they're not on any medications. Then around 1/3 of the patients who were on PPI, here as seen in this yellow color bar, were taking it on their own. They were not taking according to a doctor's prescription. They were taking as and when required. Now, if they have a heartburn, they will go to the pharmacy and take some medication, or they show the old prescription and just get some medication. So this yellow color bar, or 1/3 of the patients on PPI were using it without any doctor's prescription. And only 11 of the 209 patients underwent anti-reflux surgery. For the data, we can see that many of them were unsatisfied with medication use. So you can see the red color bar that around 20% nearly at all the times were unhappy with my medication use. And over the 12 months of follow-up, a majority of them, or not, I wouldn't say a majority, nearly 50% of them were not using medication. This was from the patient's perspective, or we looked at patients. What about the doctor's perspective? So this is another small study we did where we looked at the knowledge, attitudes, and practices among doctors managing gastroesophageal reflux disease in GERD settings. And here also, we found that many of the doctors didn't know the importance of pH impedance testing studies. So you can see this pH impedance study was only seen by this little tiny red triangle over here. And only half of the doctors advise patients for a follow-up visit. So patients were just falling out of the follow-up. And about half of the doctors advise patients to avoid bread, meaning that our doctors are very observant that they have noticed that this bread is a major issue. Especially, I'm sure as GPs, you all would also have noticed patients would be saying, okay, I can't eat bread at all. I will get bloated. I will get heartburn after I eat bread. So a little interesting study we did again on this bread was, I'm sorry, I can't show it to you very clearly. So we went, you can see my car, And you can see all the bread samples we have taken from about 28 local bakeries. We took the chun pan, what we call. We went to 28 bakeries and got these bread. We sampled the middle of the bread aseptically and cultured on Sabarod's agar, and that is for fungi. So fungi grows on the Sabarod's agar. And we found that around 11 of our samples, 11 of our 28 samples grew yeast or Saccharomyces cerevisiae. And of the samples who grew yeast, so 11 of those samples, their pH levels of that bread, we also measured the pH levels of the bread that we looked at. The bread which grew Saccharomyces cerevisiae or yeast had a lower pH, significantly lower pH than the bread that didn't grow yeast. So you might be wondering, okay, what does this mean? Why would there be yeast? Now, if you look at it, if you're baking a bread, you're supposed to kill all the yeast. The yeast we put for icing of the bread should die during the baking process. But for some reason, Sri Lankan yeast is not dying, probably because of unethical practices, because from what I gathered during our data collection was that many bakers, the assistants are being paid only for the amount of bread they bake, not for the time they spend. So they want to make many batches of bread or number of bread as much as possible, and they want to do it fast. So they will put double or triple the number of amount of yeast you usually would put. And so you'll have a high amount of yeast. And then another thing is in Sri Lanka, we measure our standard by the rattala, pang rattala, that is the standard size. So if you bake bread, the water will evaporate and your bread, the weight of the bread will reduce. So the Sri Lankan practice is just to wait until the bread rises enough to look like a bread and then take it off the oven. You will have more water and a higher chance of your yeast surviving inside. So it's kind of weird. We have to do more research on that, and this was just the initial step, and there has been no similar studies elsewhere for me to compare. So yeah, that could be a reason why some bread causes acid reflux in some patients. So we don't know, we'll have to look about it. Right, so I have finished all these parts. I would now like to talk about the psychological perspective of heartburn. Now, we talked, I just have two more to finish off. Why do we talk about the psychological perspective of heartburn? Of the associated factors we found in our study and in majority of the studies done worldwide, stress and mental issues play a major role for heartburn or GERD symptoms. Now, I've showed this picture. This shows a Jewish family. This shows a Palestine family, and they're all crying. Now, crying is a physiological phenomenon. It's a physiological phenomenon. It's a lacrimation. It's a physiological reflex. But how does our emotion causes this physiological reflex to occur? So likewise, heartburn is also something which can be triggered emotionally. So I did a search on lyrics.com for songs with the word heartburn in it, and I found about 375 matches. And they talk about maybe it's reflux, maybe heartburn, got to mask these feelings, pour up till my heart burns. So heartburn is a very common thing in when you're talking about emotions, and it's generally associated with sadness and heartbreak, and you can see there are many books on that as well. And even it's mentioned by Shakespeare during Shakespeare's time when he talks about quotes about heart burning between two parties. And if you look at our Sri Lankan context, we also say so Sri Lankans also, we also understand the relationship between stress and heartburn. So the symptoms of GERD is shown to be associated with many psychological factors and disorders, be it stress, anxiety, panic attack, OCD, grief, depression, whatever. And there are many research showing the relationship between stress and psychological stress and GERD. And in fact, some studies have shown that the effect of psychological stress will increase the symptom severity of your gastroesophageal reflux disease. And they have also noticed that patients who had asymptomatic erosive disease, I talked about the subcategory or category of patients who don't have who have erosive reflux disease but who are not symptomatic. They have found that these asymptomatic patients have a lower stress level than those who are symptomatic. And also heartburn and regurgitation can have severe impacts on the life quality of patients with gastroesophageal reflux disease. So how does this happen? How does stress cause heartburn? It is through the gut-brain axis and through the different main neural pathways. There are parasympathetic pathways via the vagus and symptomatic pathways via the thoracic spinal segments, etc. And this is a discussion on its own, but I just wanted to show you that stress and heartburn are together. And so this is why whatever you do, I believe that it's important to take a clinical history and identify the psychological factors affecting the patient, not just asking about, okay, how was your, how many times you have heartburn or things like that, but maybe take a look at the patient's psychological aspects, assess the stress levels. And are they going through a breakup? Are they going through a divorce? Are they going through some money problems? And we will see that maybe there is some correlation. If there is excessive preoccupation with the symptoms, if there are multiple unrelatable, unexplained symptoms, so if they say atanatridana, methanatridana, arakatridana, so you know the category of patients I'm talking about. And if there is episodic appearances of symptoms during stressful times, okay, if the patient himself says, okay, I didn't have this for the past few weeks, but we identify that it happens during stressful times, it's likely that these patients have heartburn associated with stress of maybe it could be functional heartburn, but we can't guess like that. And these are images taken of me at doing the pH impedance testing and manometry. What we've also noticed, we can't obviously do research on this, but we've noticed that if the patient is excessively anxious during this painless procedure, this is a very painless procedure, but sometimes as soon as we take the catheter, the patients will start, saying, being very anxious. So now we have got this guessing game where we identify if the anxious is too irrational, okay, this patient must be having a functional disorder. We've gone to that level as well, but of course it's not documented at all. So if a diagnosis of functional heartburn is made, please look at the guidelines and see how you can treat with medications such as TCAs or tricyclic antidepressants, selective serotonin reuptake inhibitors, etc. And they're shown to be efficacious in functional disorders according to literature review. And if needed, these patients can be referred to mental health professionals. There are also neuromodulation therapies showing, but their use is, or their effect is controversial. So let me come to the last slides. So conclusions and future perspectives. So what did we learn? Prevalence of GERD symptoms is higher in Sri Lanka than the estimated global prevalence. Identifying true GERD via pH impedance testing is the cornerstone for effective management. And we must improve investigation facilities. Right now, around Sri Lanka, only about 5 or 6 centers are there with functional means they might have the machine, but it's not working, or we might not have the catheters with functional pH impedance testing. And even at the National Hospital, we do it just maybe once or twice a week per one patient. So we really need to improve the facilities. The problem with pH impedance catheters are that they're expensive. They're about 80,000 rupees, but in abroad we use them once, but in Sri Lanka we tend to use them several times after a proper cleaning method. So this is the problem. But I believe that if a patient is really in need of this, we could, and if he or she's quality of life is really affected, this investigation is useful. You also must evaluate and manage the associated lifestyle factors, and especially mental stress, and it should be a part of your patient management. Lifestyle factors play a major role. I believe that just prescribing omeprazole or just prescribing something is not enough. Talking about lifestyle factors, about the dietary factors, about ways of sleeping, uh, things I things we talk about, sleeping 2 hours after having a meal, head elevation, all of those things play a major role. So, and also, once you identify these GERD patients, they should have a definite plan that includes a proper medication, proper surgery, a proper review pathway, and not following them. Okay, so one thing we learned was that another problem was that there is no Sinhalese name, or I think there's no Tamil name either, for gastroesophageal reflux disease. So patients, this was a very difficult thing, especially when we try to communicate with patients. They would say, I have gastric or gastritis. Usually the commonest word is gastric. And so with the help of language experts, we coined this word Amasha Galanalika Prativaha, which translates directly to gastroesophageal reflux disease. It's quite a mouthful of a word, but I think it's important to name a disease, because if you don't name a disease, you cannot teach about it. And I don't think we talk about gastritis for patients, but they don't know about this. They're two totally different physiological mechanisms, but the patient thinks it's the same thing. So education starts from at least identifying this and giving it a proper name. So I will end my talk. I wish you all a lot of love with the proper heart without heartburn. And I also need to show my gratitude to the College of GPs for their kind invitation, and also Dr. Priyadashika for moderating this and communicating with me, and Dr. Eranthi for coordinating the whole lecture, and of course to my audience who are incredibly great at listening at 9 o'clock in the night and showing your appreciation for furthering your medical education. So thank you very much. If you have any questions, please feel free to ask me. Dr. Priyadashika, now over to you. Okay, so if there are any questions, you can ask in the chat, or if not, I think we can call it a day.
Hello, Dr. Nilanka. I have a question
Hello.
for you. Can you hear me?
Yes, I can hear you.
So I have a question for you. The question
Yes.
would be, according, I don't know whether you have done a research on this, what type of PPIs in Sri Lanka are the most effective in a long-term basis when used on a long term, maybe for maybe for 3-4 months? Would it
So
be the esomeprazole, the rabiprazole, omeprazole? According to you, what do you think?
So again, I don't generally prescribe, but what I found in my literature review was that there is not much of a difference between the different classes. So what we call as PPI resistance is if you have the highest dose at about 40 BD for 8 weeks. If the patient doesn't recover from that or has no improvement, then it's considered treatment resistance. To answer your question, from what I have done, my literature review is that there is not much of a difference or no difference, but what practically the consultant gastroenterologists or consultant physicians or the gastrosurgeons, so I think their ideas would also play a role. I'm sorry, I cannot talk much without authority on that.
Thank you so much. Thank you.
Yeah. Then someone, Lochana Suryarich has asked, we are giving the PPI with NSAIDs and aspirins. Is it okay to practice rather than confirming without GERD? Okay, so that's a very interesting phenomenon. In our all island study, we did find, I didn't show those findings, but it is a practice to give NSAIDs with GERD. So if you look at even the KAP study which I showed here, we found that
Are there any more questions?
Yeah, so we found that heartburn, we found that NSAIDs and aspirin are doubled up with PPIs, and I don't think it's a good practice. It's not recommended anywhere in the world. It's probably only a Sri Lankan thing, I don't know, or an Asian thing. So I believe it's not correct. And also, what would be the second line after PPI? So according to the literature review, if I go back to the this is PPI, optimization of PPI with twice daily regime, and what they say is PPIs, and if there's H2 receptor blockers, you can prescribe it if it's we have nocturnal symptoms and such. So domperidone, if you're suspecting things like gastric reduced gastric motility or reduced gastric emptying, if you think that is causing heartburn, then domperidone and things like that would be also great.
Thank you, Dr. Nilanka. I wonder whether are there any more questions? You can raise your hand and forward. Then I think we can wind up. On behalf of the CPD Committee of the College of General Practitioners of Sri Lanka, I would like to thank Dr. Nilanka for the interesting lecture and wish you all the best in all your future activities. Thank you very much once again.
Thank you very much.
Sorry for the inconvenient cause in time to time. And my thanks goes to College, Dimuthu and the office staff, CPT committee for making this event a success. Thank you very much. Good night.
Good night.
Thank you, madam.
Thank you.